All right, and hey there, I'm over here. Welcome to Back Talking. I'm Todd Wigurski, and I'll be your host for this show. Now, this is the so-called pilot episode of Back Talking, and I'm still fleshing out the technical aspects of the show so things could break at any point in time because I'm really pushing the limits of my computer today. So we'll see if it can hold together, and more like if I can hold it together throughout this all. Now, I've been on the air for about 10 months now with my Back Talking podcast, and you can go find that. It's on iTunes and Stitcher Radio. But what I love about this Blab medium is the visual aspect, that we can show pictures. It's so much easier to teach somebody or to talk about anatomy, x-rays or MRIs when you can show somebody a picture. So I'm loving this. Now, the advantage of the Back Talking show is that you get me, a real live person who has spent 20 years helping people with back pain. And I'm actually speaking to you from my laboratory, so to speak, as we just finished up a session of seeing patients. So this is what I do. Now, I know there's a lot of information out there about backs. Some is good and some is bad. And my motivation for doing the show stems from my frustration with several websites out there that deal with the spine. Now, on these sites are forums. And on the forums, people with back issues can come in and post about their problems. They're looking for solutions or for what other people had done with similar circumstances. And on these forums, there are moderators. And these moderators are essentially out patrolling the site. And they want to make sure that nobody is handing out any medical advice. So the people are left to get answers from other lay people that have had similar circumstances. And most of the time, the answers that they give are pretty bad, and their information is it almost makes me cringe. But the moderators, hey, they're very biased, and they love handing out their advice. So my frustration is stay away from these forums. So this show is my way of helping bridge that gap between people who have questions to those who have answers. And I'm not saying that I have all the answers. I don't. And if I don't have the answer to something, I'll go out and I'll find somebody that can. So I'm really excited about using Blab to do the show. So the format of the Blab episodes are what I'm calling Spinal Grand Rounds, where I present a real life case to you, and you can follow along and see if there's similarities between what you're struggling with or somebody you know is struggling with. And it's also meant to be educational. I'm going to deviate from the path as we talk about the case to talk relevant to what's going on with the person. So let's jump into the first spinal round that we're going to do. All right. And again, here we go. We got a lot of moving parts, and hopefully the technical aspects will all work out. So first of all, I should have talked. You can reach out to me at todd@backtalkinghelp.com. Email me. I want to know what you're struggling with, what your issues are, and we can use it for a future show episode. And in future shows, I'm going to open it up as I get more used to this medium, and it'll be a Q&A session. So those will be fun as well. So again, now onto our spinal round case of the day. This is a 33-year-old female. Her history is 10 years off and on, low back pain. There's an unknown onset. She can't recall any single incident that brought it about, and she denies any falls or trauma. Her pain level is manageable, meaning that she gets through the day, she functions pretty well. But what she notes is standing for a period of time, greater than 15 minutes, increases her lower back pain. She has back pain only, and she denies any leg symptoms at all. Her exam findings are essentially negative. There's no sign of nerve root tension. Now, what I mean by that is that there is no sign of the nerve being irritated anywhere along its pathway. Now, in the back, nerves can be irritated by many structures. It could be the disc. It could also be a muscle, as where it pierces through in our glutes. It's called the piriformis. And it also could be irritated by bony structures, such as with arthritis, where we have bone spurs, where it rubs on the nerve as it passes through. Another exam finding of hers of note is her lack of overall lumbar spine motion. She has no lumbar flexion with forward bending and the lack of a uniform curve. So with this, I have somebody bend forward trying to touch her toes. And with her, most of the movement occurred in her thoracic spine. She was able to get there, but she compensated for the lack of motion in her lumbar spine with excessive motion in her thoracic spine. And with lumbar extension, she basically hinged at L5. So with this test, you're basically doing the opposite. You have somebody lean backwards as far as they can with their arms up over their head. Now, the same applies here. You should see a uniform movement in the spine. And with her, she basically had no movement at all, and she hinged at L5. She also had some imaging study. It was performed 3 years prior. She had an MRI done. And what it showed was a disc bulge at L5. And she had mild degenerative disc disease, or DDD, at that L5 level as well. There was loss of disc height at L5. So in future episodes, I'm not going to dig into this too much about MRI findings. I'll dedicate whole shows to that topic. Now, the clues are there. Now, what do you think is causing her trouble? So now we're going to deviate off. We're going to break away from our case, and we'll come back to it in a few minutes, but we're going to talk a little education. And the spinal column, which sometimes also gets called the vertebral column, it's composed of 24 bones. We have 7 bones in our neck, the cervical spine. We have 12 bones in our mid-back, or the thoracic spine, and we have 5 bones in our low back. It's also called the lumbar spine. And we also have the sacrum. That's our tailbone. That's that bone right there at the top of your butt. Now, your spine has 3 curves to it. 2 are lordotic, meaning, and those are the cervical and lumbar spine, and that lordosis means it curves towards the front. We have 1 kyphotic curve in the thoracic spine, meaning that it bends towards the back. Now, the spine has several functions. Obviously, it's to help us move, to do the things that we do, to bend, twist, run, jump, all that fun stuff. And it's also like a shock absorber. Now, those curves give it almost like a spring-like quality to absorb shock. But it also has a function at the other end of the spectrum of movement and being flexible. It has to protect our vital spinal cord and nerves. We don't want anything to happen to those guys. Now I'm going to jump out. I'm going to show a different program here. Let me jump back to the top. And let me zoom in. Let me move my camera. That should be fine right there. And here we're looking at the spine. Here it is. Here's the top. Here's your pelvis down below. Lumbar spine, thoracic spine. We see the ribs. Head is way up here. Here's our cervical spine. And we'll just give it a little spin. Woohoo. There goes Mr. Thin Man. We're going to zoom in. Lumbar region. Lumbar region, again, is the lower back. It has 5 vertebrae. Let me spin it around a little bit. Here's that sacrum down below, sits in the pelvis. We have 5 lumbar vertebrae. I'm going to jump in. I'm going to show you an x-ray just to give you some relation of where the spine sits in the body. Here's the person's stomach. Here's the back. Here is that tailbone, and here's the lumbar spine. Nice, beautiful, nice curve to it, that lumbar lordosis. Here's an MRI. Same thing. This image is reversed from before. Here's the front of the body. Here's the back. And here's the block part of the vertebra. Right here. Here's the spinal canal. Down in the lower back, we don't have the spinal cord. The spinal cord actually ends up here about T12 or so. But these are the nerves. This is called the cauda equina. Right there. All right. Let's jump back out and back in. Okay. Now we should, let me pull out a little bit to make sure we're getting it all on camera. I think we are. We're good here. This is something I've been testing to see what shows up on the camera. We keep zooming in. I showed you the whole spine, and then we just had the lumbar region. And now we're looking at what's called the functional spinal unit. And it's nothing more than just a fancy term for 2 vertebrae and the disc that sits in between them. So here's vertebra 1. Here's the vertebra below. And here is the disc. Now, this is a healthy looking disc, nice and fat, nice and tall. Now, when this occurs, when we have a nice healthy disc, the load that's carried by the spine, and you can think of your spine like the girders of a building that handles the load, 80% of the weight is carried here in the block part where there's more substantial bone. 20% back here where the joint is. So 80% through the block, 20% through the joint. Let me exit out. I'm going to jump back into our other program because we're going to take a close-up look at that functional spinal unit. Let me spin this guy, and I'm going to take him down a layer. And we're going to talk a little bit about the pertinent anatomy here. Let me move my camera. This is what I want you to see. Let me get the cursor off of there. Here's the block part of the vertebra. Here's the vertebral body. Here's 1, here's 2. Block part. Here's the intervertebral foramen. Foramen is just a fancy Latin word for opening. This is where the nerves exit out in between the vertebra. These are the spinous processes. So when you palpate or push on somebody's back, these are the bumps that you're feeling. I'm going to give you a little spin here. Let me bring this around. Now in the back, so I've rotated it. Here is the joint. This is where the 2 vertebrae interact with each other. Here is the joint. It's kind of cut away. You would have another vertebra above interacting right here. Let me spin this back around. Oop, I want to go back the other way. And I'm going to add in the disc. This next layer up adds in the disc. Here is the disc. Nice fat, nice tall, 80% weight bearing in the front, 20% in the joint. I'll spin this. Here is the joint capsule. We added in a capsule. Here is where the 2 vertebrae interact with each other. These are called facets, and these can get painful. Hint, hint, I'm giving clues. Let me jump back. All right, moving forward. We're going to talk about the disc. And this, we actually lose part of it on screen. The disc, let me pull over this way because the fun stuff is over on this side. The function of the disc is just to allow for extra spine motion in between the 2 bones or vertebra. It also has to handle that load that's coming from one vertebra to another, your body weight. So it has to be able to handle that compression. The disc is composed of 2 parts, the annulus fibrosus and the nucleus pulposus. The annulus is arranged in rings. It is this part of the disc right here. There's about 15 to 20 annular rings around the nucleus. And its job is to hold the nucleus in its place. And it's also to help with that compressive loading. The nucleus on the inside here has a gel-like or almost like a toothpaste consistency. And the job of the nucleus in here is to help distribute the load. It's almost like a hydraulic function to it. It helps distribute the load over a greater surface area in between the two vertebrae. Now, this was a cutaway section, so we're kind of looking down on top of a vertebra. So I'm taking this, and we've turned it this way. Whoop. We've taken this, and we're looking down on top of it this way. Okay, so what do you think was going on with this person? We had several clues along the way. Standing for greater than 15 minutes increased her lower back pain. She had loss of proper motion in the lumbar spine with both flexion and extension. She had loss of disc height at L5. Remember how important that was. Now, I'm sure, back to our patient. Okay, wait a minute, lost my way. Now, I bet, that's what I said. Back to our patient, I bet the first thing that everybody wants to jump on was the bulging disc aspect of her presentation. There's a point that I want you to listen to and understand. It's very important. If we were to place 3 asymptomatic, meaning that they had no pain whatsoever, so 3 asymptomatic individuals into an MRI machine and scan their lumbar spine, 1 out of 3 would have a herniated or bulging disc. So 33% of the time, 1 out of 3, 33% of the time when we stick somebody into an MRI machine, they could show a bulge or herniation, but it's asymptomatic. And guess what? In the cervical spine up in your neck, 1 out of 2. So 1 out of 2. So if we were to take 2 healthy people that were asymptomatic, place them into an MRI machine, they would have a disc bulge or a herniation, even though they had no pain whatsoever. So this is an important point as well. You have to treat the patient. You don't treat what's on the MRI. You don't say you got a disc bulge. Oh, here's the culprit. You have to look at the whole patient and what's going on with them. So let's understand this patient's issue. She had loss of disc height. So with a disc bulge, there is a loss of disc height. The ligaments become slack and they don't control motion. Those vertebrae, the way they move, it's almost sloppy, especially at end range. She had increased facet joint pressure. She had loss of normal joint alignment, and she had increased weight bearing on the facet joints. And that's just a total recipe for pain. And as we jump back, I'm going to show you a herniated disc in the lumbar spine. And this is what I'm talking about. You can see here, nice, healthy, fat, tall discs. Looking good. Spacing is good. Down here is a bulge. This is rather a herniation. This is a big herniation going on. But what happens is that the 2 vertebrae are getting closer together. We've lost that 80-20% weight distribution. More the joint in the back, because the vertebrae have gotten closer together. Those joints are closer together. They're almost becoming pinched. And they are becoming pinched, not almost becoming pinched. All right, cruising right along. Treatment progression for this lady is as such. We're going to move quickly through this because I'm just wanted to get you guys up to speed here with Blab, Spinal Rounds, Grand Rounds. First goal is to get out of pain. We want to see no pain whatsoever. The reason we do this, we try to get them out of pain as much as possible, is that pain changes everything. It changes how we move. You don't move properly when you're under pain. So first, we get you out of pain. Second, we're going to find those faulty movements. And in this case, her lumbar spine didn't flex or extend. So we already know what's going on there. So we're going to work with those faulty movement patterns. And we're going to groove new motor patterns. And what I mean by this is that her brain says, I'm going to bend forward. And this is how I do it. I move excessively in my thoracic spine. We have to rewrite that software. We have to teach the brain, this is how you move. We're going to move, your thoracic spine moves, your lumbar spine moves. We have to rewrite, regroove motor programs back into the brain. Then we're going to work on her endurance. Most people lack endurance. This is what gets them in trouble. I'm not talking strength. We're talking endurance. And finally, we hope to get her to maintain so that she doesn't have a slip up and regress and have a setback and have this condition again. So with no pain, we treat the chemical pain. How do we do that? Ice, electric stim, spinal manipulation, possibly even NSAIDs or some type of drug therapy. We find that faulty movement patterns, like I was talking about. We have tissue overload. Tissue overload always causes tissue damage, which causes pain. We're going to groove the new patterns. We're going to have perfect practice so that she knows how to move. All right. And that's it for this first episode of Back Talking Spinal Grand Rounds. And I hope you enjoyed it. I'm learning. I'm working my way through it. Hey, next meeting, we're going to meet up next Friday, January 15th, around or about 1 p.m. Hopefully, if things go as I hope them to, meaning I'm done with my day of seeing patients. That's the bottom line right there. You got a topic for discussion? Hey, I want to hear from you. Email me or leave a comment here on the Blab. My email is todd@backtalkinghelp.com. Again, that's todd@backtalkinghelp.com. And here I am back, hopefully on camera. I want to hear from you guys. Thanks a lot for joining me. Send me an email. Talk to me. Let me know what your concerns or questions are. And don't worry, all things are kept confidential. You won't be exposed on the air. So we'll see you next week. And thanks for hanging out with me.